So hi everyone, I'd like to talk to you about Ebola, SARS, how epidemics are modeled, and the community response associated to epidemics. So my name is Paul Douay. I'm healthy and confined, like I hope many of you. I'm based in Geneva. I'm the director of a nonprofit called Personal Data IO, which is focused on data protection, as the name indicates. I'm also a board member of an organization called My Data Global. I'm a mathematician, I'm a data protection specialist, but I'm not an epidemiologist. Today I would like to talk to you about, first of all, the science behind epidemics, and then what data could do to address some of the concerns raised by particular characteristics of COVID. So the first parameter I would like to talk to you about is this reproduction number, which is essential in epidemiology. It's the average number of people that would get infected by one person. So this R0, sometimes called R0. So if R is greater than 1, you have an epidemic on your hands that is growing exponentially, because each person will infect more than one person on average, which in turn will infect more than one person on average, and so on and so on. If R is less than 1, then the epidemic is exponentially decreasing. The situation is much better. Another factor that is very important in epidemics is this infectious period. When are people infectious? And in COVID, the situation is a bit unusual. So let's look at this graph. You have this incubation period in white. You have this symptomatic period in gray. And in red, you have the infectious period. So we can see that the infectious period starts earlier than the symptoms. So this is very problematic because you have this at the intersection of this infectious period and incubation period in orange, you have a pre-symptomatic period where people are infectious. It's very problematic, but it's not completely original, or we have been in similar situations in the past. So for instance, with Ebola, a disease that was very present in Western Africa, the situation was that people could be infectious and having symptoms, but those symptoms were very similar to other diseases. So it was very hard to know that this person was infecting others with Ebola because they just thought that their symptoms corresponded to those other diseases. And it would only be realized by the time they were hospitalized that this was actually Ebola and that they had infected potentially many people during that whole infectious period. So let's dig in a little bit deeper into the viral parameters for COVID. So now we're back to COVID. So remember, there was this crucial factor of R. Now in this graph, R would correspond to the area under the curve. So what this graph does is it shows you the distribution of R over time since the infection, right? So you see the x-axis is the number of days. You can see that most infections occur around 5 days after the infection. So the average number of days like this, that's called the serial interval. It's the delay between one infection to the next. And then you can see 4 colors, and those 4 colors correspond to different ways that one can get infected. So let's look at the easiest one first. Let's look at the light green one. These are environmental factors. This is when someone touches a surface where the virus is present, and it's very unlikely, but the virus has managed to survive, is on their hands, they touch their mouth, and then the virus enters their body in this way. And this corresponds to only 0.2 in the total R. In dark green are the asymptomatic carriers who contribute to spreading the disease. There's just no way to tell, but the contribution is fairly low in the end. In dark blue, that is the simplest to understand. It's someone is symptomatic, is coughing, and that contributes to spreading the disease, and that corresponds to a factor of 0.8. In light blue, on the other hand, this is the really problematic part, is the pre-symptomatic carriers who contribute to spreading. So they're not yet coughing, but they're already spreading the disease. This corresponds to a total of 0.9. So if you gloss a little bit over the numbers, the fairly simple summary of this slide is to say, on average, each person infected will infect 1 before being symptomatic and 1 after the symptoms show up. So if the suggestion is just to isolate people with symptoms, you're not killing the epidemic there. You're certainly slowing down its spread, but you're not fully killing it because the total contribution of the non-dark blue contributions is still above 1. Now, with Ebola, what was done? Well, with Ebola, the idea was that as soon as someone was showing symptoms, we would isolate them, and then they would be monitored by the community for compliance with this isolation, and they would be helped as well to make sure that they would be okay. And this might last a long time, but at least we would know that they were not infecting others with Ebola, and so they would get this reproduction number below 1. So what could be done here? Well, what could be done here is to use those dark blue symptomatic areas as sensors, as detectors for the light blue. Right? So we could go back in time, in a sense, and turn back the clock on the infection. So think that, oh, okay, now you're showing symptoms, you have been infected, you might have infected someone before you were symptomatic. Right? Remember, on average, each person will infect one person after having symptoms. It's clear they should immediately isolate then, but they would also, on average, infect one person before having symptoms. So once you have symptoms, let's isolate you, but also try to find the person, the average person you might have infected. And so this is turning back the clock. How would that work in practice? Well, you could do contact tracing. So what does that mean? It means that someone, let's say subject A, would go about their day, not on day 1, not knowing they have COVID. They are not showing any symptoms. So they would go around their day at home, in the train, at work, and back at home, and live a normal life, more or less normal life. But then on day 2, they would wake up with a fever. So they would know right away, oh, something's wrong, let me take the test. They take the test is positive. And then as soon as we know the test is positive, we go back in time. We go back to the previous day's behavior. All the people that were in contact with A that might have been infected get an instant signal that they are at risk, and so they can take the test again. And in this way, we can cut down a lot on the propagation. So a team in Oxford has done all the computations necessary to establish that indeed this should work. The numbers should work and reduce together R to below 1. Now, it's really important to understand that this is a method that exists in the lab or in someone's computational model, but it has to work also within a community. So I would like to cite here Miles Fahlman, who wrote a thesis on the cultural logics in Vietnam in relation to SARS. SARS, the disease that ran through Asia in the 2000s. So whether the biomedical response for months in the future or response to both SARS-CoV in 2002, so the original SARS, and SARS-CoV-2 in 2020 is a social response. Right? So it's very important to understand that all of those techniques exist, but they have to be accepted by the populations affected by this disease. So let's look at what a social response could be. Let's look at South Korea's social response. In South Korea, the government released a lot of data, the government implemented some apps, but civic hackers, a lot of them implemented a ton of different apps. For people to manage their contact tracing, for people to access open data about cases, open data about the cities, and so on. So they could really assess what areas were at risk and what could be done by individuals to protect themselves in light of this danger. But the model from South Korea is not transferable directly. This surveillance would need to be proportionate. The contact tracing has significant civil liberties implications. So we will have to make sure that we're not going overboard and building a system that we'll regret building once the epidemic is over. There are also privacy concerns for those infected. In South Korea, their name was not released, but very detailed behavior of those individuals was released. They took this particular train, they were going to this church, then this place, to the extent that they were essentially identifiable, and sometimes their behavior was not the most socially accepted, and this created a lot of privacy concerns. Also, South Korea, like many Asian countries, was much more ready for SARS than European countries would be. And so they were able to take more coherently, more quickly, strong measures that might be rejected here in Europe. And indeed, those measures have intense politics associated behind them, associated to them. Let me explain this in the next graph. We already saw that there was a lot of politics in deciding this left vertical line when to start doing something to mitigate the epidemic. It's still ongoing in the UK and the Netherlands, for instance. The decisions were very different from in other countries, what was decided in other countries. We're in the part right now in most European countries called the hammer by Thomas Pueyo. So this zone where different measures are implemented to try to get the reproduction number below 1. Social distancing is one of them, but there are many different aspects to this, and very detailed decisions to be taken. Can people travel more than 500 meters from their home, more than a kilometer? Can they go and jog? Can they go to work if they have some essential work to do? What is essential, and so on and so on. But over time, hopefully, we'll understand the virus better, and we'll be able to take more granular measures, decide on more granular measures to keep the numbers low. They will not go to zero right away. It will take an extensive amount of work to get it to zero, but for a while, we'll keep it to a manageable level, and deciding what measures are necessary and which measure to implement to achieve this contained level, and to try to fully suppress the disease, that will require intense politics. And indeed, this politics will be there because it's important that the population accepts the measures that are taken. And so it's important to understand that this disease lives in each of our bodies, but the way to fight it has to be decided together by a community. This is also a lesson from Ebola and other diseases, where it's easier to explain and easier to imagine how this might work. So let's imagine you have Ebola spreading into an area, and let's imagine that you can just come from outside as an international organization trying to solve this problem. Well, you have different villages where you're trying to get this disease to disappear. So you could limit the number of trips between different communities. You can try to root out the disease from one village after the other. And so people would know, oh, this village is affected. They would travel less to that village. And at the same time, within the village where the disease is present, people would isolate themselves better to prevent its spread within the village. So this is easier to imagine within a village, harder to imagine within a city. But this is really important, and this is probably one of the ways out of COVID. So on the left here, you have a figure taken from this paper called "Eliminating COVID: A Community-Based Analysis," where you see what is now a familiar graph. TC is the moment of intervention. So before TC, you have an exponential growth. After TC, you have theoretically reduced R below 1, so you have an exponential decrease in the number of cases. Now, what this paper brings is a perspective that this situation should be analyzed community per community. And so COVID could be eliminated if the community-to-community reproductive number, so the expected number of other communities to which a single infected community will transmit the virus, is reduced to less than 1. So we find that this community-to-community reproductive number is proportional to the travel rate between communities and exponential in the length of the time delay before community-level action is taken. So what this paper is hinting at is the possibility that you could fragment the population where COVID is present into different communities. What would be crucial is that each community on its own understands that once they are affected, they need to react right away to avoid this exponential increase. And you need to fragment your population to those communities so as to limit the number of trips between the travel rates between different communities. Right? So this is a way to imagine what the future measures might be. But it's very hard to match to our everyday life in Europe, where, especially in cities, where all those communities are interlinked and interacting very much. So one proposition to get out of this that is trying to use all of those insights into how previous epidemics were fought, but also understanding the importance of data in order to be able to go back in time to do the contact tracing, is to use data to empower communities to fight COVID. The way this might work, and this is a theoretical construction shown here, but on which many people have started to work, is to imagine creating some commons, plural, around personal data, on which a values framework would be embedded. So this values framework would be rooted in something called the My Data principles, which are principles around individual empowerment around personal data, based on mostly consent and a better understanding of how data is used. So there's this whole community that I'm part of the board of, this My Data community, that has developed principles around this. But those commons would be community-led, would follow legal principles like the GDPR, ethical principles as well, encouraged and developed by the WHO. And very importantly, it would be time-bound. It would be limited to solving the COVID crisis. And once this data commons is constituted, then this data could be shared, or others could be allowed to do analysis on this data. And these others could be academics or governments and international organizations. And this selective sharing, or this allowance for computation while preserving privacy of the individuals, would be enabled through cryptography and mathematical techniques. And this is really important because the data that becomes relevant to understanding COVID is very intrusive. It's health data, of course, but it's also social data, how people interact. And so they would have a control over this, and they would seek to get benefit from this data while preserving privacy. And of course, this will require extensive development, but through the My Data community, we think we can mobilize quite a lot of developers working towards this. So the My Data community is distributed through hubs all over Europe, all over the world, and many people in the My Data community are participating in hackathons. But there are still difficulties, of course, difficulties tied to surveillance that still needs to be proportionate. We need to decide on what to collect, and it's still unclear from epidemiologists what data would be useful. And this is defined, this has to be defined by communities for communities. So culturally, it's still quite a few steps ahead of what people understand right now. And if you start using data as much to understand epidemics, and if you start segmenting people into communities, this can very quickly lead to ostracization and social stigma. This particular profession, for instance, would contribute drastically to the spread of the virus. Everyone would know this, and then it would become very problematic in terms of social stigma for those professions. There is also concerns about social inclusion. Whenever you act through digital means, you're excluding some people, either for accessibility concerns, but just also because access to devices is expensive, for instance. And there is questions of tolerance for different lifestyles. And of course, deep ethical questions associated to all this. Those are all very valid concerns we're very aware of and we're trying to navigate. But if this whole project sounds interesting to you, then I would encourage you to join the Slack channel of the Slack workspace of My Data, and in particular, the channel Corona Data. Thank you everyone for listening, and I wish you a very great day. Bye.